It is with great pleasure that I introduce my colleague, Dr. Brigitte Wiedemann, who's going to be doing the moderation for the afternoon. Dr. Wiedemann is the branch chief of the pediatric oncology branch at the NCI, where we both did our fellowships back in the early 90s. Seems like a long time ago now. And I will turn it over to her. All yours.
Awesome. Yeah, I'm so excited. This is my one of my favorite meetings. I'm just coming back from ASCO, and I can tell you this is so much more fun than ASCO. And it's so interactive and so much to learn. And thanks to our speakers this morning, and also to our keynote speaker, Dr. Glade Bender, I feel we're really making progress in solving the most challenging problems, including how do we design clinical trials early on and get to active therapies more quickly. And I think the afternoon is targeting solid tumors, where we are lagging a little bit behind compared to leukemias, obviously. And so we'll hopefully get a lot more insight this afternoon, and this will start with Dr. Brian Ladle from Johns Hopkins, who will talk about challenges in the development of novel therapeutics of sarcoma. Welcome, Brian.
All right, good afternoon, everybody. So I'm thrilled to be able to present here today. And I mean, as you saw from my earlier questions, right, I'm not the most experienced one here in the room, right? I don't know even who CTEP is, right? So, sorry, I muted the microphone by accident. But I'm glad to present today. So Dr. Glade Bender, such a masterful approach, right, to clinical trial issues. And so maybe some things, maybe share a few thoughts as well. I feel like these talks can be a little bit of kind of editorial type comments, and I took a few maybe liberties there, but share some data that we're working on as well. So my interests are specific to immune therapy. And I think immune therapy, as far as incorporating into pediatric solid tumors, has some unique challenges as opposed to small molecules or a direct pathway we're trying to inhibit, and that I think is every grant starts with, right, checkpoint inhibitor is not effective in pediatric sarcomas, right? We know that monotherapy is not the answer, so then how are we going to figure out how to do more than that? But if you'll permit me, maybe this week has been a little more than most. One of these kind of existential weeks as a pediatric oncologist for me. I know there's researchers, clinicians, everyone here. The work we do in pediatric oncology is an incredibly noble and important work. And it's unique, right? It's not a 9-to-5 job, right? Caring for these children, trying to help these families through their worst nightmares, right, is really an honor to do. And but it's tough, right? This week, it's been hard to be a sarcoma doctor, right? Trying to convince a 19-year-old to do high-dose ifosfamide when all she wants to be is home, right? Talking about, are we going to irradiate a 1-year-old's brain because they have extension into the brain, right? All these terrible conversations we have to have. And it's not easy. But I know many of you here, right, talk about patients, collaborate, and I know so many of you give your hearts and souls to this work, and it's a noble work, and I'm pleased to work with you. But it's also urgent, right? There's a lot more that we need to accomplish. So the tumors that I think about are sarcomas, right? So as you see, pediatric cancer is rare to begin with, and then these are just a subset, so only about 10% of pediatric cancers are these sarcomas that I think about. And kind of general overview, right, if it's a tissue in the body, you can have a sarcoma of that tissue. I swear every time I go to sarcoma tumor board, the pathologist uses a term I've never heard before, right? They just pull these terms out of somewhere. Specifically in pediatrics, right, there's sarcomas that more in adults. The ones in pediatrics we think about are bone, osteo, and Ewing's. muscle-related, right, rhabdomyosarcoma, and then the bucket of soft tissue sarcomas, a few of which are limited there. So these are diseases that we've known about for a long time. And the treatments, when I sit down with a family on day one to talk about the treatment, right, this is what I talk about. So the current regimen we're using for most of our intermediate risk patients at Johns Hopkins, first patients treated in this protocol was 1991, okay? Osteosarcoma, the first patients getting MAP therapy was in 1982. That's still our frontline therapy. Ewing sarcoma, right, the latest invention of doing chemo every 2 weeks instead of every 3 weeks, 2001 was when that trial started. The current paradigm for non-rhabdo soft tissue sarcomas, right, in 2007. So the term stuck was used before. I feel like especially in the upfront therapy we're kind of stuck, we're a bit locked in. So I distinctly remember a conversation I had with a family with Ewing sarcoma. We talked about, they were one of these families, wanted to know about the biology, wanted to understand their disease. We went through all this, and then we went through the treatment, and the mom at the end, she just kind of paused and says, "Is that all you've got?" Right? You just told me all about this cancer, and all you're recommending is still chemo, surgery, and radiation. And unfortunately, so far, that's kind of where we sit day one with these families. So it's interesting, and as I alluded to, and others have shared, but during this time, right, we have gained so much detailed understanding of how these sarcomas work, many of them. And, right, I can't do justice to any of them, but just for instance, right, we now have this list that keeps growing of translocations that are present in sarcomas, right, the driver mutations we understand. Right, this is a paper done just down the right over the road at NCI. We know rhabdomyosarcoma, we've profiled hundreds of these. We know these individual driver mutations, and right, we understand so much about this disease. For instance, synovial sarcoma, right, we understand it's one little protein that gets one little nubbin of another protein stuck to it, and the Sweet-Sniff complex falls apart and doesn't work. Right, we have some really incredible in-depth understanding into some of these cancers. So how do we continue to translate this knowledge into new treatments? And it's been a theme of the day, and we've heard lots of thoughts, and forgive the redundant ones that come from me, but maybe just some other things to throw into the mix. So some of the obstacles that we have to progress, one is the obvious, is just being rare diseases. I'll share my thoughts a little bit, right? The success of chemotherapy has certainly, I think, limited progress, right? Especially in the upfront therapy. And our clinical trial approaches and the limitations of those, I think, are also have limited our progress, and maybe some thoughts on how we can get around these. So rare diseases, right, influence patient accrual, especially if you're stratifying, right? For instance, the MATCH trial, we tried to put everyone in their specific bin, and we ended up with 2 people in one bin, right? So that gets very difficult. There's some obstacles I don't have solutions to. I'm just stating the obvious here. But time to completion of these studies is also, right, a long process. So just in comparison, my mother-in-law was just diagnosed with triple-negative breast cancer, right? Reading that literature, trial of 3,000 women randomized between 2 different studies, completed in 2 years, right? It's just incredible the pace that you can make, that we don't have that luxury in pediatric cancers in general, but especially in sarcoma. The cost of doing clinical trials in multiple sites is just, it's become unwieldy, and it's very difficult, and that this is not an endeavor that's really reimbursed. And so, for instance, division, to have a robust clinical trial infrastructure, it's really that division itself is putting money into this. It's not like it's well compensated. So if I say I'm going to open a trial at 10 different sites, right, that's 10 different sets of individual red tape you have to get through in order to do this. Thankfully, consortiums are trying to work on this, but for smaller trials, smaller diseases, right, it's really a limiting factor. So the limited samples to study, as well as disease models, right, for instance, Ewing sarcoma. So we all know we don't even have a great mouse model to understand that. the samples that we get from clinical trials is very limiting, and is also limits our ability to make progress. So just being pediatric patients in general comes with its own scope of ethics and things that you have to navigate in these trials that just, again, as I was preparing this talk, I just kind of kept sinking lower and lower in my seat, right? More and more obstacles. So this is something I've thought about. The success of chemotherapy is limiting as far as our ability to make progress, in that it would be an incredibly high bar for you to have a new drug or a new regimen that you're going to say is better than chemotherapy, especially in the sarcoma world. We know resistance is the issue, but upfront response is almost always there in most pediatric sarcomas. So, of course, these regimens were developed with our goal of, you've heard that analogy, they take my kid to the edge of death and bring them back, right? That's the kind of level of toxicity that we already have baked into these protocols, and then we're trying to add new things to it, right? It makes it very, I think, very difficult to kind of, get a signal even of what's next to do. The difficulty of combination therapy, we talked about that some this morning, is, right, again, you already have combination therapy in the regimens that we do, and then you're trying to add something in addition to it, right? For instance, osteosarcoma right now, right, can we add in a TKI, multi-TKI to standard chemo? The toxicity, right, how do we navigate that? Do we do it concurrent? Do we do it sequential, right? All these questions are difficult to understand in the current, I think, clinical trial structure. So, but we all know that we need these combination therapies. It's not, right, NTRK fusions, fantastic, you just need one drug, but almost every other cancer, we know it's going to take multiple strategies in order to achieve success. So one thing I wanted to think about a little bit is our current clinical trial approaches and what those limitations are. So what are the best outcomes to follow? So is it overall survival? Would it be progression-free survival? Or is it a biologic endpoint? I think each of these endpoints can certainly have a role, especially when we're talking about rare diseases. You have to have a large cohort of patients to show overall survival, and it has to be a long study. So maybe that's not the best approach, for instance, for early agents, right, and trying to incorporate new things into your study. Progression-free survival, right, whenever you do this, right, everyone says, oh, is this, are you going to be able to, make any conclusions just based on progression-free survival, and then the biologic endpoints are important. So I remember talking to one of my families, and they were wanting to do a clinical trial, and he said, I don't get it. Why are you just going to give my kid the same drug until it doesn't work anymore? We've talked, like, we need to do this, then we need to do this to be effective, and he didn't understand why we would enroll him on a clinical trial where all it was just one drug, and we're just going to wait until you develop resistance in your cancer. So the I think an essential point in clinical trials is we need correlative studies. And this is something I've been thinking about a lot in our need for on-treatment samples, especially for different targeted therapies. And this has been, I think, an obstacle in pediatrics of how to adults do this regularly. They do on-treatment biopsies on clinical trials. And I do think it's something that we as a field should think about, and that I've sometimes pondered, what are the ethics of enrolling kids on trials that don't work, right? So it's almost like you're putting them at risk by taking the drugs, but we're literally getting no information out. We just do a large clinical trial. At the end, it didn't work, but we don't have any samples. We don't have anything to learn from it. And, right, so what are the ethics of that as opposed to ethics of a procedure that's about as risky as accessing your port, right, to do like a on-treatment biopsy of a sarcoma, for instance. So I do think that's something, for instance, as a field we can think about and potentially iterate and think about. So I'm a big fan of window trials. For instance, do a therapy first, then, for instance, you can do a surgery or something and see, right, did your therapy itself hit its target? And really the need for financial support of these correlative trials is something that definitely lags in pediatric trials, right? Companies might support the trial, or COG supports the trial, but no one's supporting the correlative science, and which I think is imperative in order to make these iterative changes and these improvements. So, okay, is there any optimism? So I maybe want to, and of course, right, this wasn't a polished talk because I'm too much of a mess this week, but wanted to give maybe just a couple of examples of things where we've tried where maybe, right, it's kind of an example of kind of clinical trial approaches. So one that I want to share just briefly is, can we target the specific fusion proteins in sarcomas? And in our case, at Johns Hopkins, we have a clinical trial ongoing. I'm the pediatric PI, so I see the peds patients in conjunction with our adult GI folks, looking at a vaccine specific to the fusion protein that causes hepatocellular, fibrolamellar hepatocellular carcinoma. It's one of these fusion genes that every cancer has. So is that fusion point potentially an immunologic target that we could go after? And so this clinical trial has been ongoing. Here's the group that's doing, again, Dr. Mark Yarshawan and Marina Beretti are the adult GI oncologists who have been driving this. So the trial is giving vaccine plus immune checkpoint inhibitor, and then, right, continuing it kind of as long as it works. You see they start with kind of multiple vaccines to begin with, and then space to more of a boosting strategy after that. So we've treated, for instance, 12 patients so far, right? And we've seen 3 that have had really a significant response. Fibrolamellar is one of these cancers where you remove it with surgery if you can. So we've had several patients, for instance, who their tumors have shrunk, they've gone on to surgery. And the reason I wanted to highlight this is not that, oh, we had 3 patients that respond. It's what can we learn from those 3 patients, right, that then we can take forward into the next clinical trial iterations. So this is one of our patients, a 14-year-old, relapsed 5-6 times, right, is in complete remission now for over a year with this vaccine therapy. So super exciting for this patient. We are generating T-cell responses to this fusion protein that was not present before. But one thing I wanted to highlight this specific patient. So this was a young adult who had multiple lesions that shrunk and had one lesion that shrunk and then started to grow, right? You see it there on the bottom. The decision was made, I think we can render him NED with surgery, and so they went ahead and did surgery. But what that gave then is we had lesions that were responding and lesions that were not responding, and what could we learn from those lesions? So this is just some of the preliminary, sorry I don't have a pointer very well, right, to highlight some of these differences, but I can aim it at the screen. Thank you. Oh, how about that? That's good. Oh. Now distract me even more. Okay, that's right. So for instance, we are able to see in responding tumors, right, versus resistant tumors, there are significant differences in the immune microenvironment that was present. Today's talk is not about what the differences were, but the power of what we learned from a responding lesion, a responding patient versus a non-responding patient. So for instance, we had B cells, almost like a tertiary lymphoid structure present, whereas in the resistant tumors had a significant granulocyte infiltrate into these tumors. There were, in the resistant tumors, there was significant upregulation of several checkpoint inhibitors, right, or several immune checkpoints that were not being targeted with Nivo and Ipi, right? So LAG3, TIM3, right, were significantly upregulated. So for me, the important, right, or the very exciting outcomes of this study is, all right, were we able to do a trial where we were able to give an agent and see a signal, right? Did the treatment that we were giving, did it do what we hoped it would do, right? So in this case, did it generate a T-cell response? And we were able to see that, yes, it did. But then we were able to get tumor tissue because I think the field is also replete with evidence that a single vaccine against a single protein is probably not sufficient either. But we now have clinical trial samples that we can interrogate and say, all right, when we knocked down wall 1, what was wall 2 and 3 that are now present that we can attack and go after? So for instance, in this clinical trial, right, we're now combining things with a metabolic inhibitor to try and change the tumor microenvironment that we know is suppressive there. So, so for me, right, one of the again, I think as we think about clinical trials, especially in the immune space, right, are there ways that we can do trials where we can say, all right, did I hit the target that I think I wanted to, right? We've got to have the assays to do that. And then even from small patient numbers, what can we learn as far as what determines who's a responder versus what determines who's a non-responder, right? So my time is up, and Erin Resch will be a subsequent speaker. She'll talk about one of our other topics looking at canine osteosarcoma, right? And this is a study where the first drugs we were able to treat was because of CCF funding, right? It really got this study off the ground. It's currently an R01 funded endeavor, right, where we're treating canines, and that I hope, again, we are getting that same, we're using an immune agonist called a sting agonist, right, directed or injected directly into the tumor with the goal of can we bring in the immune response, right? Can we engage the immune response in these tumors? Our IHC analysis says that we do, right, in not everybody, and that's, again, what we need to understand. Why do some tumors we get a great infiltrate and others we don't? But for instance, in a trial like this, we're able to say, yes, the drug I had, I gave it and it did what I wanted it to do. Is it the answer? No, but it's a step, right? And it's a first step. And right, as we do these trials where we can understand, right, what's the first step, then, right, our subsequent analysis, here looking at upregulation of other compensatory mechanisms, we can say, all right, we had step one, now what's step two and step three, and hopefully we can iterate these trials and move forward without having to do a 50-patient phase 2 trial of a single drug that we know by itself probably is not going to be effective. So, all right. So thank you again for everyone's for your attention and thoughts, and I very much enjoy discussion afterwards to think about it. But I'm hoping that we can convert this optimism to optimal outcomes for our patients. So just acknowledge this is the large study team for the fibrolamellar study, and then as well my lab, and all of our team doing the canine osteosarcoma study, and we'll hear a little bit more about the sting agonist here later with Erin. So good again. Thank you all. Thanks.
We have time for one or two questions. I maybe have one question, Brian. Do you think the use of cell-free DNA in patients is going to help with some of the questions you have when we can't get real biopsies?
Right, and that's always, that's kind of a holy grail again, right? Yeah. Can we just draw blood and get all the answers we want? As far as immune therapies, no, right? I don't think we're going to be able to, because it's what's going on in the tissue that's really important, and the compensatory mechanisms there. So I do think I think that technology is going to be really important as far as tumor evolution, right? And understanding how your therapy, especially like directed therapies, is changing their tumor, right? And how it's adapting to it. I think those will be very important technologies to understand that.
Thank you so much, Brian. That was an incredible talk, and I think you posed a lot of things that even I, as a fellow who's just starting out in the field, have wondered about when we learn about these treatment strategies that we use and talk to patients about them. Again, as someone who's very naive to all of this, what kinds of things do you think we can do to enact some of these changes that you're talking about? I mean, we heard earlier about how Europe seems to be doing some of these kinds of studies and able to. Is there something we should be doing, or as someone who's starting in the field, do you have advice for people like me to be able to do this in the future?
No. Do I have advice? Yes. No, of course. People use the term like quick, efficient clinical trials. That's not COG, right? So COG doesn't run trials like that, right? They're too paralyzed by trying to have, consensus with too many people. And I wish it weren't so, but agencies and foundations like this support a lot of the work. Dr. Glade-Bender, I really appreciated what you said about conversations with pharma, right? We had a clinical trial. We were trying to treat 20 patients with osteosarcoma with nivolumab, and BMS pulled out, right? They're like, no, we're not going to provide drug anymore, right? For them, 20 patients is crumbs, right? But they said, no, we're not going to support that trial, let alone pay for, any of the trial infrastructure. So I've been very inspired by the advocacy, right? How we can get our own patients involved in that. But so I know there's a lot of funding that goes into basic science, but there also has to be, I think, much more funding go into these, kind of pilot, iterative type clinical trials where we can answer some questions, and right, we need the biologic signals to know if we're hitting targets. But yeah, that was rambling.
As recently as last week, I had to abandon because my research council and IRB was nixing it for the less than 18-year-old. It happened to be a sarcoma that mostly affects greater than 18, so it wasn't one I was willing to go down to the mat on. But I think it would be helpful for the community if somebody wrote a white paper, if you will, and made some of the really good arguments that you did, and then experts in the field actually talk about true parameters around what is a minimal risk biopsy and what is a more than minimal risk. Because as you described, no more than accessing a port, I thought that was very powerful.
Mm-hmm. No, yeah, and I've wondered, I'm not the person to write a white paper like that, right? But right, to get people in the field, and I think advocacy too, right? Patient groups, have to be willing to say, yes, we would, potentially do this. I guess I've just really been struck with why are we okay giving kids drugs that we don't know if it will work at all, right? Why are we okay with that toxicity and then not learning anything from that trial, right? Where's the, I feel there's really an ethical argument there. And, that maybe we shouldn't do that at all then, right? But we know that that's not where we're going to make progress, so, yeah.
And the other barrier, right? You have to come up with a funding for the research.
Right, yep.
Yeah, I'm just going to tack additional onto that. I mean, I've been sitting in sarcoma meetings at COG for 25 years, and for the initial biopsy, it's a bit of a challenge because patients are often biopsied at outside hospitals and they come into these referral centers and there's no tissue, or, the problem with Ewing's is that you can now make a diagnosis on a glass slide with 5 microns of tissue. Yeah. And the advantage that neuroblastoma had for 20 years is that people wanted to know the N-mix status. And so to know the N-mix status, you had to get tissue the size of a pea at least and send it off to Philadelphia or wherever the tumor bank was. And so they accrued hundreds, if not thousands, of samples to make a huge amount of progress. And in Rhabdo and Ewing, you've got these little nothing of biopsies at diagnosis. And then patients, to re-biopsy them again at the beginning of therapy is a huge challenge. Nobody wants to do that. Mm-hmm. Getting the tissue later, if you ask patients, they're more willing to do it. And then we get to the level of Julie's and your points about paying to both do it, store it, and then analyze it. So there's a lot of challenges out there, and we'll continue to try to fight those battles.
Yeah.
Hello? Oh. Hello? Hi. I'm over here in the corner. No, I just had a question. You talked about patients that were responding versus patients that weren't responding. And I wanted to know how you would handle, for instance, a lesion that responds versus a lesion that doesn't respond in the same patient. Mm-hmm. We see this all the time in NF1, and specifically with selumetinib, where patients, have tumors all over their body. Some of them respond and some of them don't. Yeah. Maybe that just begs the question that biopsies are appropriate for both of those in that situation, but I just wanted to see your thoughts about that.
Right, no. And the example I showed is like an immune therapy, where I think this will be even more common, right? As those tumors break apart, they become kind of their own independent tumors. So I feel like even clinically, you can make an argument that you should biopsy both sites right, leukemia world, they can do bone marrow biopsies all day long because they say that's what they need to understand the disease, right? And for sarcoma, that's what we need too, right? We need to biopsy those sites to understand, and I think I think especially nowadays with, clinical NGS testing and things, is it clinically, warranted now, but yeah. So I think I think patients are brave enough to do it, and I'm not talking about 5-year-olds, but 15-year-olds, right? I think they could say, yeah, I want to do it, and anyways, the pendulum has swung to, if we have to be brave, we have to be bold to make advances, and my existential crisis of the week. Thanks. Yeah.
Thank you, Brian. I think this was a great talk. I think Dr. Glade-Bender's talk was great, and I think they give us definitely some food for thought for what we can do by the time of the next CT, Children's Cancer Foundation meeting. And one of my NF patients who's on the same trial that Cecilia was mentioning, he said, Dr. Wiedemann, when are we doing the next biopsy? So patients are actually many times willing, and they know there's a learning. But I think now we're coming back to also something Julia mentioned earlier, the patient voice.